Okay, so again, thank you for having me. It's really a pleasure. And I'll just get started on the talk on pseudohypoparathyroidism. So here. So I have no disclosures. So here, let me just first, I need to get rid of this floating panel. Excuse me. Hide floating meeting controls. Okay, perfect. So I have a clinical and research focus on Albright hereditary osteodystrophy. And just so you know, I'm going to call this AHO from now on. And this involves two conditions, pseudohypoparathyroidism type 1A and pseudohypoparathyroidism. I established the Albright Center at Johns Hopkins and Kennedy Krieger Institute many, many years ago. And that's how, in fact, I got involved with the OI Center through working with the OI Foundation, through working with many OI patients at the Kennedy Krieger Institute with Jay Shapiro. So it's been, I hate to say it, over 2 decades. And about 7 years ago, I moved to the University of Connecticut and Connecticut Children's. And I established the Center for Rare Bone Disorders, where I transferred the Albright Center to and also started an OI Center. So I've been very fortunate to really be a part of OIF continuously. I've evaluated a large population with AHO from around the world in my clinic, well over 1,000 patients, which has taught me a lot and met wonderful people. My research is bedside to bench and back, and I evaluate patients in the clinic and investigations at the bench with a focus on a genetically engineered mouse model of AHO that we developed. And I was a few decades ago, I won't say how many, in Michael Levine's lab and did this with him. The goal is to improve the health and quality of life in AHO. From my point of view, that's the bottom line, and to define pathophysiological mechanisms and new therapeutic modalities. So let me get started. And Laura told me that, and I know this from other sessions, it's a very broad audience. So I really apologize if it's way too basic, but I want everyone to follow, people who aren't an endocrinologist, a peds endocrinologist like I am. So just to explain the difference between hypoparathyroidism versus pseudohypoparathyroidism, both are characterized by hypocalcemia and hyperphosphatemia. And in hypoparathyroidism, there's a lack of sufficient production of parathyroid hormone by the parathyroid glands. The PTH levels are typically low or inappropriately normal. And there's a normal response if you give PTH with appropriate increases in urinary excretion of cyclic AMP and phosphate. In pseudohypoparathyroidism, however, there's a failure of target tissues to respond to PTH, and there's a defective cyclic AMP and phosphatoric response. And PTH levels are increased, and this usually develops slowly in early childhood. And one very important thing with pseudohypoparathyroidism, and Laura also said to mention clinical pearls, so I tried to highlight those, is that the PTH is typically not present at birth or infancy. So don't expect to see it then. So what happens is the PTH and phosphate increase first, with the calcium levels being initially normal. So that can also be tricky because people see a high PTH, they expect a low calcium, but it actually declines later. So you might see it after the PTH elevation. The PTH resistance occurs only in the proximal renal tubules, and I'll explain that later, but not in the collecting ducts or the ascending limb. And therefore, the hypercalciuria is not as significant as it is for endocrinologists, you know this, as in hypoparathyroidism. And multi-hormone resistance can be present, and I'll show you why. So in AHO, as I said, there are these two conditions, pseudohypoparathyroidism type 1A, and because you're going to get sick of me saying that word and so long, I'm going to say PHP 1A or 1A, and then pseudohypoparathyroidism, which I will refer to as PPHP. This condition is caused by heterozygous inactivating mutations in a gene called GNAS, and GNAS encodes the alpha-stimulatory subunit of the G protein. So this causes basically a defect in G protein coupled signal transduction. And this is a classic textbook picture that you're probably all familiar with, in which the ligand binds to the G protein coupled receptor. It needs this G protein complex, of which the alpha stimulatory subunit is one of 3 subunit components. And that is needed in order to get this whole signal transduction cascade that involves activation of adenylyl cyclase, formation of cyclic AMP, and then cellular responses. And this defect leads to resistance to hormones that require this mechanism. So here is a picture of a patient with Albright hereditary osteodystrophy, discovered by Fuller Albright back in 1942. Just an incredible clinician, scientist, and endocrinologist who described a phenotype involving an osteodystrophy, so bone deformities. So actually, Albright hereditary osteodystrophy is describing the phenotype, the bone phenotype for PHP1A and PPHP, which involves short adult stature. And again, a clinical pearl that's incredibly important. You will often see that children are normal stature, even tall. And so if you use short stature as a criteria, you can miss the diagnosis, and that happens a lot. So what ends up happening is short adult stature. You get brachydactyly, shortened fingers, brachymetacarpia, and brachymetatarsia, shortened metacarpals and metatarsals. And this is what you may have, if you've heard of pseudohypoparathyroidism, you think of this classic 4th finger shortening with a shortened 4th metacarpal. Here you can see it in the toe, the shortened 4th toe with the shortened 4th metatarsal. You also often see shortened thumbs, shortened big toes. And this patient on the bottom, I followed into adulthood. And what you'll see is patients grow, it gets even more pronounced. And you can really see the striking deformity of the 4th metacarpal, the 4th toe, but look at the 3rd toe, that's abnormal as well. I want to just point out a few terms that are clinical pearls in terms of what's seen in this condition. There's Potter's thumb, which is a shortened, stubby thumb that you can actually see right here. Then there's a very famous sign called Archibald's sign, which is when you take your hands and make a fist. If you have shortened metacarpals, the knuckle will be absent, or you'll see a dimple. And here you can see there's no 4th knuckle. And that is a hallmark sign of brachymetacarpia. These abnormalities evolve with age, so everyone knows infants have short, stubby fingers. And so you often won't notice this until patients get into early childhood. So I have pictures of so many patients, and I just put a smattering of them here because you don't only see 4th finger shortening. Everyone looks for that, but you see anything and everything. So maybe here's the classic, and you can even see the dimple where the knuckle should be, but you can get a short index finger. This patient really had everything shortened except the 2nd toe. You can see all the fingers shortened. You can see differences in one hand versus another that are very striking. So it's really anything and everything when you start to see a lot of these patients. What's really unique to AHO are these heterotopic ossifications, but specifically limited to the subcutaneous layer. So this is a really unusual finding. And if you feel these ossified lesions under the skin, you should think of AHO. I often see them as a peds endocrinologist on a hand wrist bone age, where you can see just little ossified lesions. You can even see them on random films. In a foot film that had been done, you can see these tiny lesions. They can be pea-sized, they can be sand grains even. They feel just like sand over the skin. This is a patient who brought in this hunk of bone that had been removed from his leg. It shouldn't have been removed, and I'll explain that later. But you can see big bone formations. And as you can see, there's even on histologic evaluation evidence here of bone spicules, on H&E stain, even bone marrow with adipose. So here you can see a huge ossification, and sometimes you have to do an MRI to really make sure that it's just beneath the skin. And I'm going to get into another condition as to why that's important. I blew these up for you just so you could really see this. But what's really fascinating is these bluish tinged lesions form first, oftentimes. So I look for these very closely on every patient I examine. And sometimes it'll even be a little bit elevated, and that eventually can coalesce and form a big ossification. And then what's also really interesting, and you don't always see this, but you sometimes do, is these little punctate areas can form at the top of the ossification and exude like this whitish powder, which is actually ossified fragments. These are not calcifications, they're ossifications. It's true bone. So with these subcutaneous ossifications, they're a major clinical problem sometimes. They can cause a lot of pain if they're in areas where you weight bear, for example. They can restrict mobility if they're over a joint. They can develop spontaneously. They can develop in areas of pressure or trauma. For example, even the bridge of the nose, like where I wear my glasses, or a belt buckle, or especially shoes that are too tight. That's like really a bad place where they form. I've detected them sometimes in the delivery room or soon after birth. You can biopsy them to verify they're an ossification. And of course, nowadays, we can do mutation testing, as quickly as we want for confirmation. And what I want to just emphasize, because a lot of times these are removed and it can lead to regrowth and a worse situation. And I've seen that happen many times. So you only remove them if there's a need, if there's impairment of activities of daily living, because they're just such severe pain, like if they're on the foot, or limitations in joint mobility. So I'm not going to do a scientific talk in any way, but I just wanted to show a couple slides that just make it a little bit more tangible and interesting, and why it's so much fun to go back and forth to the lab and also analyze patients in terms of clinical research. So we looked at almost 70 patients with AHO over a period of up to 16 years for how these form, because the evolution wasn't really clear. And about 70% of patients with both PHP1A and PPHP have these ossifications. So not all, but about 70%. Of course, we may be missing some. I don't x-ray every part of their body. So this is based on palpation. They can increase in both severity and size. Males are affected more than females, so we're investigating for possible hormonal etiologies. And there's a greater severity in patients with frame shift and nonsense mutations versus missense. It's just been very interesting to see that the really severe ones, about 95% with nonsense and over 90% with frame shift get the really severe ones, whereas with the missense, not so much. So the question is whether this can really be a biomarker for subcutaneous ossification formation. So I do keep the mutation in the back of my head. There's no correlation with BMI or hormonal resistance. In this mouse model we're working on, I'm only showing you purely because it's just very neat to see, but it recapitulates the condition of PHP1A and PPHP very well. And this is an exon 1 knockout mouse, and you can see these ossifications everywhere. But the question is, are these really under the skin? So we have the advantage in mice, unlike in people, that we could actually do CT imaging of tons of mice, and in every case, they're all subcutaneous. So the thought is, at least I strongly think, that virtually all of these are subcutaneous if a patient has AHO. And what's really interesting is the bone formation appears to arise from parafollicular areas around hair follicles. So this is an H&E stain, low magnification around a hair follicle. This is alizarin red or alizarin red, however you like to say it, where there's a calcium showing the calcium staining. Here you can see the bone and even the marrow within, and this is all within the subcutaneous tissue. And we've been doing lineage tracing studies and I'm working on that for publication right now. I want to also point out what's a very important problem, just like in OI, are dental abnormalities. And this is a patient with PHP1A. They often have many missing teeth, many abnormal teeth, abnormal tooth chambers, teeth that fall out. And this is a typical, really tomogram of the teeth in this condition. And we're currently looking to see in PPHP what the differences are. So I want to just summarize there. So the manifestations common to both PHP and PPHP are bone related. This is termed Albright hereditary osteodystrophy, and it's all the things I showed you with the shortened fingers, shortened metacarpals, the adult short stature, and all of these things are due to premature epiphyseal fusion that's actually secondary to accelerated chondrocyte differentiation. And this is caused by the GNAS mutation itself. And this premature acceleration, for all of you who do bone ages, causes a markedly advanced bone age, or at least it can, not 100%, but often does. And then the subcutaneous ossifications. So there's your bone phenotype that had actually been described back in 1942 by Fuller Albright, and then later when he found pseudo. You don't always get all three of these things. You'll get the adult short stature prior to the day of treating with growth hormone, and you'll learn about that very soon. But some patients, like I said, only 70% maybe of the ossifications. Not everyone has striking hand-foot abnormalities, but these are the things to look for carefully. And you can learn so much from looking at the hands and feet. And there's also, when Ashley Shoemaker was a resident way back when, and I was junior faculty, I won't say how long ago, we found an increased prevalence of carpal tunnel syndrome. So just keep that in mind as well, probably from the structure of the hands. They're very, small. And then the dental abnormalities. So here we get to the kicker. What are the differences between PHP1A and PPHP? They have these similarities, but what's different? In PHP1A, there's resistance to multiple hormones whose receptors use that pathway I showed you, the G protein coupled signaling pathway. There's PTH resistance. You'll see markedly elevated PTH levels sometimes. Sometimes it's mild, but it can get very high, 300s, even, I've even occasionally seen into the 400s. There's a decreased calcium and increased phosphate. Well, what happened way back when, back in the day of Fuller Albright, biochemically, he could measure, the calcium and phosphate. And he saw these patients who had a low calcium, a high phosphate, but they were resistant to PTH. So what did he term it? That's how the term came to be, pseudohypoparathyroidism, because they didn't have hypoparathyroidism. So that's where the term started way back then. It can result in hypocalcemic seizures if it goes unrecognized until very late. The goal is to catch it early. The resistance, like I said, isn't always present early in life, and it's important to remember because many times, when the PTH is seen as normal early on, people will say it can't be pseudohypoparathyroidism, but it can. It usually develops later in childhood. And this low calcium phosphate is really marked by the elevated PTH and phosphate appearing before the low calcium. So like I said before, the calcium can fall after the PTH rises. The TSH resistance is milder. You get a low, or actually, it's usually not significantly low, but you can get a slightly low or even a normal total T4 or free T4. As infants, what is really key to know is they often present with hypothyroidism at birth. That's something that's very important to recognize. It can be mistaken for congenital hypothyroidism. These patients will fail their newborn screen, and it's not congenital hypothyroidism, it's TSH resistance. So this is a pearl. Think of PHP1A in an infant with these ossification who fails the newborn screen. That should be immediately in your mind, and you can catch PHP1A early because there's a very strong likelihood the child has PHP1A. The PTH may not be elevated yet. Again, I'm reiterating. If you successfully treat too, this is important to know. You've treated and this patient's euthyroid, but the weight gain just accelerates like crazy. Think of PHP1A, and I'm going to show you about the obesity that can develop later. There can be LH-FSH resistance, which doesn't typically manifest as increased LH-FSH. People look for this. It's very rare that it manifests that way. Instead, it manifests with signs of hypogonadism, with incomplete pubertal progression, maybe getting halted at 10 or 3 or 4. The females will often have abnormal menses, oligomenorrhea, even amenorrhea. The puberty is actually normal onset. It's not advanced, it's not delayed, you typically normal, you get the exceptions like you do in everybody. There's also GHRH resistance that leads to growth hormone deficiency that I'll get into a little more detail, but I want to just set the basics here that 2/3 of these patients with PHP1A have GH deficiency. Often it's a partial deficiency. If they're not treated, they have significant short stature as adults. And just historically, patients with PHP1A end up, I'm going to tell you around 3 SDs below the mean, but again, I'll show you some more about that. Many are not short as children. I must have said this 10 times, but I feel the need to because I've spent my life trying to get this across to people and get the word out internationally because many children are missed for this reason. And the growth deceleration can get masked because, as all of you know, severe obesity, when it's really severe, can accelerate growth. And you don't wait for the growth deceleration to test for growth hormone or treat because the epiphyses can fuse fast, especially at the onset of puberty. Other hormonal resistances can be present. They're not as common. They're not really clinically relevant either, but glucagon and calcitonin resistance can occur. Although calcitonin resistance may be clinically relevant, which I'll show you just in a few minutes. So, what you also develop, and many of you know this well, is typically moderate to severe obesity. And as infants, you really very often observe, and even in young children, extremely severe obesity. So there are early onset obesity panels done, and so PHP's now picked up a lot on those random panels. The birth weight is actually in the low normal range, and then the weight typically accelerates rapidly. There's a wide range of cognitive impairments that goes from anything from very minimal disabilities to profound delay. So really a truly wide range of functioning. And psychosocial and behavioral issues are quite common. A lot of ADHD, what's called, quote, autism, and that's just put into this one big category, but we've been working on trying to dissect this out more. And they're often very socially immature. They have medical issues, cognitive impairments, and just a very difficult life. So advocacy is really necessary at all stages of life. I've learned a lot from the OIF in this regard that's really helped me and the patients. So PPHP they have no hormonal abnormalities. They have normal hormone responsiveness. And because they're the opposite of pseudohypoparathyroidism, Fuller, Albright, and his colleagues term this pseudohypoparathyroidism. This is really difficult for the patients, with these terminologies and people understanding what they are. There's no severe obesity in this, even though it had been thought for 7 decades that there isn't. We found when we studied this. They're often SGA at birth. That can be a sign. The cognitive behavioral issues remain unclear. They overall have much higher cognitive and social functioning. They'll go on often to college, higher education than that, even have families. But we're currently doing a study to look at maybe subtle differences because this isn't clearly elucidated yet. It's typically unrecognized until a patient is an adult. Then it can even not be recognized, but the most common way it's diagnosed, and probably the most common way a pediatrician, a peds endocrinologist, a geneticist would diagnose it, is looking at the hands of a mother of a child with newly recognized PHP1A. So a child comes in, either possibility of PHP1A or already diagnosed. I look at the hands of the parents. Here are the hands of a mother, a typical hands of a mother with a patient PHP1A. And you look at these hands and you can learn a lot from them. So if you look here, this wedding band just accentuates a bit the fact that this finger is set back forward. So of course you think, well, maybe there's a shortened metacarpal, plus the 4th finger is short. Then you look at this hand and you see that the wedding band can't be put on this finger. She actually couldn't physically put it on there, and you can see why. There's probably not a metacarpal there. Again, the 4th finger is short. And so what do? You look for the Archibald sign. And here you see clearly the absence or the shortening of the 4th metacarpal. And so this mother has PPHP. She had brought in her child with PHP1A. She indeed, on questioning her, had really hard lesions on her arm and leg. People never thought anything about them. They were indeed ossifications, and she was genetically, has PPHP. You can see here, it's not necessarily symmetric. I see a lot that's asymmetric. So PHP1A and PPHP occur in the same family. So that's really interesting. And for decades, these were thought to have the same phenotype, differing only in hormonal manifestations. And for both conditions, it's interesting because the patients, when I went to medical school, I'd read textbooks that would say that both, that these patients were all obese, that they all had cognitive deficits. So that's what's really interesting and actually just really exciting in seeing so many different phenotypes. And when you see a really large cohort, you can try to understand better what's really the situation in each condition. And these things, not just for me, but for all of you who study rare disease, these are the things that lead to the discoveries of pathophysiologic mechanisms and an understanding. So just the importance of a large cohort when studying rare disease. So the bottom line is severe obesity is present in PHP1A only. So I just took a smattering of about 100 patients with Albright just to show you. And you can see that the BMI Z-score in 1A versus PPHP, this is all ages together. I don't even know why I wrote so many digits here because it's very significantly different. And in fact, the discrepancy is much greater, you can imagine, if you look at young children, because the PHP1A patients, although they have low normal birth weights, they usually are very obese, whereas the PPHP are small for gestational age. So the severe obesity is just with PHP1A. So when you look at this patient I showed in the beginning, and I focused only on the Albright hereditary osteodystrophy, because I was showing what was similar between PPHP and PHP1A. This is that same patient, and you would determine from this that almost certainly she has PHP1A because of the obesity. So let me just summarize, because that was a lot of information, and just to put it in one chart. So in PHP1A, there's hormone resistance, but there's not in PPHP. Severe obesity, like I showed you, not in PPHP. Cognitive deficits of a wide range. PPHP, we're working that out, and maybe there's subtle things going on. But the bone phenotype, the same in both. We went over that. And I just am mentioning a couple added tidbits because they're helpful for people who may be seeing this. The carpal tunnel syndrome, be aware of in both, and the birth weight low normal in PHP1A in general and in PPHP SGA. But what I want to really stress is the quality of life in PHP1A is really markedly impaired. Medically, they're on a lot of medicines. They have to worry about, low calcium, these high PTHs. They have cognitive impairment. They're socially really impaired, have low self-esteem lots of times. So it's a very difficult condition for the patients and their families. So let's talk about the genetics. So both PHP1A and PPHP are caused by these heterozygous inactivating mutations in GNAS. They occur in the same family. So what's accounting for the differences between these two conditions, even though both are due to mutations in the same gene? And so let's look at pedigrees, because this is exactly what happened historically. Some very astute clinicians kept looking at pedigree after pedigree. And here's an old pedigree that Michael Levine gave me a few decades ago. Here you have, if there's no Albright hereditary osteodystrophy, it's white. If it's PPHP, it's half in red. If it's PHP1A, it's all in red. So you can see the father is PPHP, mother unaffected. They have one child who gets the mutant allele who has PPHP. This daughter, she now is a mother, she has children, and any children that get her mutant allele are getting PHP1A. So that's really interesting, what's going on. So it turns out that if you get inheritance of the mutation from the maternal allele, you get PHP1A, but if you get it from the paternal allele, you get PPHP. Now, this is not always genetically inherited. Spontaneous mutations can also occur, just randomly in the sperm or the egg. So let's go back to this pedigree, and you will indeed see This father has PPHP. Okay, so the paternal allele is mutated, the daughter gets it, and therefore the paternal allele is transmitted with the mutation and she gets PPHP, whereas where it's the maternal allele that she has with the mutation now that's getting transmitted, these children all get PHP1A. Many of you probably know what this kind of genetic transmission is, but for those who don't, it's called genomic imprinting. And it's due to an epigenetic marking of a gene based on the parental origin that results in monoallelic expression, not just in this condition, but in many others, typically by methylation. And so what's happening is this maternal allele is getting imprinted. It's called paternal imprinting. And it's basically just inhibition of transcription of this paternal allele. And that results in monoallelic expression. And it happens in nature. And so this is, I just think this is a fun slide that a father horse and a mother donkey end up having hinnies, whereas a father donkey and a mother horse end up having a mule. So it shows you how important this parental modification is. I'm not going to get into the structure of the GNAS locus, so I don't want people to panic here, but it used to be a lot simpler than this. And due to a lot of people's incredible work in working out this locus, a lot more has been elucidated. Many of these areas are highly imprinted, either paternally, maternally, parts are biallelic. There are regions that basically are responsible for differential methylation. But this part here is what encodes the alpha stimulatory subunit from exons 1 to 13. So you're looking at mutation when you are thinking about PHP1A and PHP. And the differences in these phenotypes reflects the difference in expression of these alleles in different tissues. And then what's really interesting is this doesn't occur everywhere. It's tissue-specific paternal imprinting. And this was identified through mouse model investigations and human studies by many people. And we have a mouse model that's an exon 1 knockout. Really, a lot of interesting things have come from all the people who've been studying the mouse models in humans. And GNAS is paternally imprinted in specific tissues, such as the renal proximal tubule, the pituitary somatotropes, thyroid, gonads. And so if you think about that, that explains the hormonal abnormalities in PHP1A that with the mutation on the paternal allele and inhibition of the paternal. So, you know, as you look at this here, you can see that's PTH resistance, that's GHRH resistance, TSH resistance, LHFSH resistance. And on top of that, there can be partial imprinting with some hormonal resistances more severe than others. And so we, as well as others, have seen this in various tissues, both in the mouse and humans. And just one thing I'll show you that's interesting, and not to get into details, but when we looked at expression in normal human thyroid tissue that was just remaining from subtotal thyroidectomies, we found that the expression of the maternal allele versus the paternal allele was very interesting. It was not complete. There was leakiness. So the paternal allele was actually getting expressed at about a 30% level with the maternal 70%. So this is, you know, interesting because it makes you think, is that why the TSH resistance is milder? And remember, I told you that we noticed these striking differences in the BMI, and I showed you the plot of how striking. Well, stemming from that, we thought way back when, you know, this was a long time ago, that may implicate paternal imprinting in the development of obesity. And indeed, it is related to hypothalamic imprinting. The melanocortin-4 receptor is G protein coupled, as you know. It causes MSH resistance. And imprinting, in fact, a lot of really elegant, beautiful work has been done by Lee Weinstein at the NIH that's shown a lot about the regulation of imprinting, but specifically he found that imprinting occurs in the dorsomedial hypothalamus in MC4R expressing cells. So this in the mouse model, we're able to extrapolate that this is most likely, you know, what's going on in the humans to cause the obesity. So that's imprinting as well. But then what happens to all these other cell types where there's no imprinting? Well, it's expressed biallelically. That would be like in chondrocytes or in fibroblasts, for example, and explains why the bone-related manifestations are the same, because there's haploinsufficiency, and because of the haploinsufficiency, they both end up with the brachydactyly, adult short stature, the premature epiphyseal fusion, and because of the biallelism in the fibroblasts, the subcutaneous ossifications. And for example, there's no resistance to ACTH and vasopressin because biallelic expression of GNAS, the expression is biallelic in those tissues, and either allele is sufficient in that case. So it's very complicated, and I'm hoping that the people who are very sophisticated are probably thinking this is so simplistic, but if you're a medical student learning about this, I feel like you sort of have to get the basics of why all of these things are happening. So in summary, the paternal imprinting is tissue specific. It can be partial. And these resistances can evolve over time because we think, the investigators who've been doing this think that actually this imprinting is evolving over time, and it can be variable combinations. So one patient may have PTH-TSH resistance, another have added on GHRH, another one with LH-FSH with the PTH resistance. The hallmark is it's always PTH resistance, almost always TSH resistance with it, but then all the others, it can be a gamush of everything. So then going on, the biallelic in many other tissues. So then they'd be the same in both conditions. I just want to touch on this because we are, a bone group. We do a lot of bone diseases. And what was really interesting is people thought maybe in PHP1A, the bone mineral density would be decreased because they have these sky-high PTHs. But what actually is the case is the bone mineral density is normal to increased even, which is really interesting because Fuller Albright, when you go back and read his original papers really carefully, you notice that he was puzzled by the fact that they had like thickened cranium and thickened bones in certain areas. So we went on to try to look at why this was. And again, this is not a scientific talk, but I just wanted to mention one study that we had recently published, because what was intriguing is we found the parental origin of the inactivation differentially affects bone remodeling, actually. So could a component of this be due to imprinting? So the mouse with the maternally inherited mutation had increased osteoblast activity and bone formation, consistent with the human findings of increased BMD. And there was data suggestive of calcitonin resistance within the osteoclast, which we need to pursue more to more clearly define. So possible paternal imprinting. But the knockout with the paternally inherited mutation had reduced osteoblast activity and elevated osteoclast activity and low bone mass. And I should just mention Eileen Shore, who is one of the great bone researchers of all time, who works a lot on POH and has a mouse model of that, has done a lot of work that's been very interesting, also finding these differences in POH, and this is specifically in AHO, but it's just been a very intriguing to me as we follow this, that even within maybe the level of the osteoclast, there's something going on. So I want to touch on one other study, and this is I'm only bringing this up in a paper up because it's very clinically relevant. We've noticed a lot of Chiari malformation type 1 in these patients in PHP1A. And so we did a combined human mouse study. The prevalence is actually about 22%. It's at least 20-fold increase of Chiari malformation type 1 or CM1 in this group of a bit over 50 patients we looked at. And it's very clinically important because these patients can develop symptomatology from it. It's unrelated to growth hormone deficiency because we had growth hormone tested all these patients, and people in case reports hypothesized the CM1 was from growth hormone deficiency and PHP1 based on a couple case reports. But it's not the case when we look at a big series of patients, and even more so, people hypothesize CM1s due to growth hormone deficiency, possibly in the entire patient population of growth hormone deficient patients, aside from PHP1A. So it really does not seem maybe to be the case, and instead our investigations in the mouse model showed really aberrant bone involvement with cranial hyperostosis, a smaller cranial vault, a dome-shaped cranium, and in fact, accelerated chondrocyte differentiation that led to premature fusion of an area very much like the growth plate, but at the cranial base, called the spheno-occipital synchondrosis. So I just want to point this out to keep an eye out for CM1. I'm only going to tell you, I'm skipping 1B because I'm going to do this afterwards. 1C is just like 1A. It may get phased out. You don't have to worry about it. It's just a milder form of 1A that may be caused by impaired receptor coupling, but not basal activity. And I'm bringing up acrodyssostosis syndromes because they can be confused for PHP1A. And it's not unusual this happens. And there are other genes within the same pathway of the G protein coupled signal transduction cascade that can lead to hormonal resistance with patients who are very short and have bone deformities that look like PHP1A. So they can get PTH and TSH resistance, in fact. And what is acrodyssostosis to people who may not know? It's really severe skeletal defects where end up very shortened fingers, toes, midface hypoplasia that can be severe spinal stenosis. They indeed get CM1 too. And here you can see it's just overall shortening within the hand. And this is a schematic I drew out just to show you how to think about these. I actually think it's pretty beautiful how logical nature is, but here you see that the GNAS gene that encodes the alpha stimulatory subunit, you have a mutation in GNAS and you block this whole signal transduction cascade and get PHP1A. But what if you have a mutation in this gene called PRKAR1A, which is protein kinase A type 1A, and that's needed to go from inactive PKA to active PKA? Well, what happens is you end up with a condition called acrodyssostosis type 1 with the severe skeletal dysplasia and PTH and TSH resistance commonly. And so you have to think of these conditions and send testing for this. If you don't find a mutation for GNAS, you need to look for this. There's another condition where there's a block in the phosphodiesterase type 4 gene, and this causes a condition called acrodyssostosis type 2. In addition, you can have hormonal resistance, not as commonly though, but they have a lot of cognitive issues. So remember that. Now we're going to 1B. Probably a lot of you see this, caused by loss of methylation at GNAS of the maternal GNS allele, and you can get significant reduction in G-alpha-S expression. There are these differentiated methylated regions. I'm not going to get into it, but specific regions that actually are greatly affected. And this is the one I mentioned here is just one that happens to be most consistent. The hallmark is PTH resistance. It often comes late in childhood. It can present with hypocalcemic seizures, and it's not too infrequent that it does. Occasionally TSH resistance, so you always have to screen, even though PTH resistance is the predominant thing. Occasionally calcitonin resistance, but they lack most other characteristics of AHO, and this is the key that you need to think about, and also the characteristics of PHP1A, I should have said specifically. They have normal cognition, puberty, fertility, and final height. Although they can be big when they're young, they can have early onset obesity. They can be similar to 1A. Occasional subtle brachydactyly, but never as striking. They can have macrosomia at birth, unlike 1A and PPHP. And Harold Buechner's group wrote about this, and it's very striking actually when you go back in retrospect and look at the growth curves. The familial type's about 15 to 20% of cases, and this is key to people who may see this because it's often due to maternal transmission of heterozygous microdeletions in the maternal STX allele, XTX16 allele, and that's upstream of GNAS, but it probably affects a regulatory element for methylation, and you can actually test for this genetically. But most cases are sporadic, a much more extensive methylation defect. I'm going to end with this last condition, progressive osseous heteroplasia, which is a GNAS inactivating mutation. Fred Kaplan, Eileen Shore have done a huge amount of work on this. And here you can see how, really invasive this ossification can be. And this is like extending way through the fascial plane into connective tissue and muscle. This child is a contracture, in fact, because of it. And it's due to paternally inherited inactivating mutations in most cases, characterized by these isolated ossifications in the absence of any other phenotypic features, and there are no hormonal abnormalities. The trauma or removal of ossifications can really worsen this even more so than with AHO. And typically it's very superficial, even very early in childhood, and then later very extensive into connective tissue, skeletal muscle tendons. And I've seen these rare overlap syndromes between PHP1A and PPOH, as have others, which is really interesting and I won't get into. But here you can see how invasive it is. You know, it's like the bone has gone everywhere. It's different than FOP. This is a GNAS mutation. So the diagnosis, I don't have to get into much here. You know, it's clinical, biochemical, hormonal, family history, but you have to remember spontaneous mutations can sometimes occur. Genetic testing, of course, is confirmatory, but I hope what I showed you is that careful clinical evaluation can really help you narrow down the diagnosis. It can help you pick up one of these conditions very early, and it can guide your mutation testing instead of sending off for whole genome sequencing for anything and everything. And there are single gene testing. You know, you can target it if you really think you know what it is. There are panels, as you all know, methylation testing for PHP1B, which we can talk about later, STX16. And sometimes you uncover this on whole exome screening. And I'm not getting into treatment and management much at all. I just want to point out a few hallmarks. I mentioned the hypocalcemia can come later after the ablation of PTH, but what's very important, you have to make the diagnosis in the setting. You have to make sure there's no low vitamin D or low magnesium when you're making this diagnosis. You treat typically with activating vitamin D, which is called calcitriol. Giving it twice a day really helps just in terms of its half-life and keeping it sustained. And anyone who treats kids, the liquid preparation is really miraculous because you can titrate really well. Then I'm going to skip this side is important for me to mention. The PTH levels you want to keep in the mid to upper normal range, slightly higher is fine, but you want to aim for, I aim for less than 130, some people 150. Over suppression is not good because you can then get excessive calcium excretion, but if you keep in the mid to upper normal range and just a bit higher, that's the best. You worry too if a persistent PT elevation for very long term could be damaging to the bones. Hypercalciuria, like explained, is not as great a problem as in hypopara because you're only getting imprinting in the proximal renal tubules. I can skip hypothyroidism because it's treated like with everything else. And what I want to say about gonadal dysfunction are just a few of these green highlighted things: that it's normal age of onset. You can get halted at 10 or 3 to 4. I told you the abnormal menses in girls is typical. If you treat with estrogen, be careful of potential DVTs because some of these patients are severely obese. They can be sedentary due to the pain of the ossifications, their physical restrictions with the small feet. And it's very hard to assess fertility, as you can imagine, in human studies. I have patients who, with PHP1A, who have had children, but you know, it's very difficult because in general, as a population, they don't go on to typical environments. They often have to live with their families long-term because of the cognitive restrictions and social impairments, or go to group homes. So we did a study in mice and a very extensive study, and we really did find marked fertility, marked decreased fertility in mouse studies. So I really gone over all of these, and this is just, you know, we know there's resistance to all these, and this is just something historical. And I find it so interesting because when I was a medical student and I learned about this, and it was actually from Michael Levine, you know, the guru of this condition. At Hopkins, you know, when I was a student, and when we learned about it, you know, the short stature, the obesity, there was, you know, is that just part of the syndrome or whatever? But, you know, you think about it, and as everything started to evolve and be figured out, the question came up, is this due to GHRH resistance, which is G protein coupled? And I'm just showing this for the people in training because everyone takes all this stuff for granted, but, you know, I'm old enough that I knew when these kinds of things were just not known. And so what we found in 2003, along with Giovanni Mantovani and colleagues in Italy, which was the same thing, it was published back to back in JCEM in the exact same journal, that 2/3 of these patients with PHP have GH deficiency from the GHRH resistance. And it's held for hundreds of patients, even the same percentage. And I've done a long clinical trial to look at the effect of growth hormone, which you must realize starting at a very young age has to go to final adult height when you're sure there's bone fusion. So it's been close to 2 decades of this study that's finally in the final last stages. So all patients need to be tested for GH deficiency as part of standard of care. Stature should not be used as a necessary sign to test or diagnose. The testing can't wait because the epiphyses fuse prematurely at an unpredictable tempo. You want to increase growth velocity as much as you can before the epiphyses fuse, and then you treat as indicated. Be very careful of obstructive sleep apnea. A lot of the kids have it from the severe obesity, and of course growth hormone can cause tonsillar and adenoidal hypertrophy. And we have published there's no increased risk of ossifications with the treatment, because people were worried about that. And this is what happens in the days before treating. You can see the bone age very advanced, the hand wrist bone age. And you can see that this patient actually has an absent pubertal growth spurt. And ends up, this is a male who ends up just over 5 feet. The bone age is this triangle. And this growth absent spurt is most likely due to this early epiphyseal fusion, but the LH-FSH resistance probably contributes. And the bone age can be deceptive. It's markedly advanced for the hand and wrist oftentimes. It does not reflect pubertal status. I've had patients come to me on Lupron thinking that the adipose were breasts and being on Lupron with an advanced bone age, but they have no evidence of puberty. So it doesn't reflect that whatsoever. It's due to the genetic defect. Don't use a hand wrist bone age for anything. You can't predict the final height. The knee bone age I found to be helpful over the past couple decades because the long bones aren't as affected, and it's more accurate for assessing growth potential, but it can't be used for final height prediction either. And I'll just show you what happens in a typical patient. They're very obese. Like I said, they're not necessarily short. Look, this patient's fairly tall, has a growth deceleration, has growth hormone deficiency, growth hormone started, and you can see the patient got to mid-parental height. The red is the knee bone age, which you can see is more delayed than the hand wrist bone age. So if I had gone by the hand wrist bone age, I would have stopped the patient's growth hormone back here. You just can't go by that. And so in summary, the short stature and PHP1A without treatment, they got short, and hopefully many of them are caught that they won't necessarily be short, but it's due to the short stature is due to the GH deficiency, early fusion of the epiphyses, and absence of the pubertal growth spurt. And historically, they were 3 SDs below the mean if not treated. I found when I test adults, these are people who missed out on treatment. Mean heights of adults with 1A who are deficient are significantly shorter than those are sufficient. Even PHP1A patients with GH deficiency end up short, about 2 SDs below the mean. So I did a clinical trial for this that's in a follow-up right now, and PPHP patients have short adult heights that are very similar to GH sufficient PHP1A patients, which you would expect, because they're equivalent in that regard. And obesity is very clear cut, how you would treat diet, exercise, but you have to remember Michael Levine, Ashley Shoemaker have shown decreased resting energy expenditure, as well as Lee Weinstein and I have done some studies. So, it's not easy to treat. Eating behavior similar to other obese patients, although some really do have increased food intake. Again, sleep apnea common. Ossifications, I'll reiterate, do not remove them. That's all I have to say at the end of this talk. Osteomacutis is isolated subcutaneous ossifications without anything else. If you get isolated subcutaneous ossifications, I would just beg you to keep this patient somewhere in a clinic, because you need to watch closely for development of PHP1A, PPHP, and POH. And dental abnormalities, motor delays, the carpal tunnel, And genetic counseling, important. All of you know this, and you can do the testing as I mentioned. And I'm going to end with this, which are the neurocognitive psychosocial abnormalities. So early intervention is very, very important. It can really have a lot of implications for school placement, job placements, makes a big difference. And one of the biggest problems is planning for the future and transition of care, which is a topic that Laura and Tracy and all of us have discussed at length, that's hard for every rare disease. And so ultimately, I end up taking care of most of these adults. It's really a problem. There are huge concerns by parents for their children in the future with being independent. It's heartbreaking, really, because many of them have to stay at home and they worry, well, what if they pass away? What will they do? They need a group home, and it's really significant if they have significant cognitive and psychosocial impairments. So I'm ending that advocacy has become something I've had to be very aware of throughout my career. In Connecticut, I was fortunate enough that I just got appointed to the Rare Disease Advisory Council in Connecticut. And so, I'm hoping we can make some strides at the state level. I've done nothing compared to the OI Foundation. When I look at everything that's been done over my career for the OI Foundation in terms of advocacy and how much it's reached out. But, it's a very rare condition, and I'm one of just a few people who see a lot of these patients. And so, I do my best to get the word out, get papers out, and give talks like this that hopefully people will pick it up earlier, because that's one of the big keys. So I'm going to end with this. That's a cartoon. I think Lee Weinstein gave this to me, and I can't remember. I should ask him. But this is a real cartoon that says, there's no easy way to tell you this, Mr. Harris. You have pseudohypoparathyroidism, a real condition. And it says, it's harmless. It's just not easy to say. But what I want to tell you, and what I hope you learned, is it's not harmless. If you're a mother who has PPHP, you can have one or more children with PHP1A, and that will really determine the course for the rest of everyone's life, because it can be a very devastating condition. Again, there's a spectrum, but I just want to say that it is not harmless. So that's really the end of the talk. I wanted to show a couple articles real quick. Nature Reviews Endocrinology as a key article, which is a consensus statement that the Euro PHP group organized for experts around the world. And I was really fortunate enough to be able to be part of this. About 40 people who got together in 2017 and came up with a consensus statement, incredibly detailed and really just so well done by the European group. And it's published in 2018. I did one that was a simplified version for pediatricians and pediatric endocrinologists in practice, as well as patients and parents in 2019. In the primer, there's really a beautiful article that's written by Agnes Linglard, Mike Levine, and Harold Eubner, and then an update in Hormone Research Pediatrics that is basically this whole group that I was a part of, giving a practical tool for physicians and patients in case you just want some things to refer to that give you a global picture in detail of everything. And there's a revised nomenclature out by the Euro PHP group that hasn't been incorporated yet here in the United States, though, that does it by genetic mutation to try to make it a little easier to follow. And OMIM has designations as well.